Now with insulin in mind, we now go on to hypothyroidism and starting thyroxine. Now I know it sounds a bit scary first up starting thyroxine in hypothyroid patients, but it's actually quite easy. This article is written by my future consultant, Dr. Darren from the Gold Coast Hospital, whom I'll be working with in February. Hypothyroidism is a common and chronic condition. Lifeline thyroxine relieves the symptoms, reverts you back to normal thyroid function. And therefore, commencing thyroxine can aggravate cardiac disease, but is relatively free of other side effects. And the concentration of TSH used to monitor therapy. Now, what did I just say? TSH. Why am I putting so much importance to TSH? Apparently, there is a log linear relationship. So, for every linear decrease in T4, your TSH goes up logarithmically. So, TSH is more sensitive to changes in your overall body function compared to T4. A different story for pregnant ladies. Pregnant ladies who are hypothyroid, I give them thyroxine, I look more for the T4 because that's what's going into the fetus via the placenta. And I'm worried about the fetus. I'm not worried about the TSH very high in a pregnant lady. I'm more worried about the T4 in a pregnant lady because that's actually what's going to go into the fetus. And as you all know, it causes mental retardation and cretinism and all those unwanted conditions if you don't treat hypothyroidism properly in pregnant women. So in pregnant women, it's T4 is a different story, but in all the non-pregnant women and all the men, it's a different story. Their TSH is the more stronger indicator of the thyroid function because there's that graph, log linear relationship. It's very, very sensitive to small changes in your thyroid function, better than T4. So this is normal thyroid physiology. Your T3 and T4 will go to your pituitary, and it has a negative effect. It inhibits the secretion of TRH from your hypothalamus and TSH from your pituitary. So in hypothyroidism, your T3 and T4 will go down, and your TSH will go high. Exactly the opposite for hyperthyroidism. But your patients may not have any typical symptoms. All the symptoms we read about in medical school, the dry skin, the croaky voice, the large tongue, the sleepiness, may or may not be present in all your patients. They might come with a very subtle symptom like oligomenorrhea, and they might tell you we had a family history of 2 ladies in our family also having thyroid disorders. That should be enough to ring the alarm bells. Yes, you could also possibly have thyroid disorders. And it's quite common. They might just come with vague symptoms of tiredness. So here's the problem. We don't have very accurate symptoms for this disease. The diagnosis is made by finding a persistently elevated TSH because there is less negative feedback because of low T3 and T4. So high TSH, low free T4, you got the diagnosis. It's hypothyroidism. Now, how to dose hypothyroidism if you have this disease? Before that, I'll briefly touch into autoantibodies. Now, I'm extremely happy with all the GPs here because all the referral letters I get, you all send to TFTs very often in patients, which is very good. You picked up a lot of thyroid patients. And I'm even more impressed with your letters because you have even done autoantibodies, which is extremely good of you. I'm very thankful to you for that. Now, what are these autoantibodies? There are thyroid autoantibodies, which you must be remembering, a thyroglobulin antibody and all that, which come back in the result. Thyroid autoantibodies, they go up in Hashimoto's thyroiditis. But it is not specific, and it can also go up in Graves' disease, which is hyperthyroidism. As opposed to TRAB, it's capital T for Tango, R for Romeo, A for Alpha, T for Bravo. TRAB, which stands for thyroid receptor antibodies, which is the autoantigen the body has made, which stimulates the thyroid to work too much in Graves' disease and makes them secrete too much of T3 and T4. And that autoantibody TRAB is very specific for Graves' disease. And even there, only 90% of Graves' disease patients will come positive, not in all 100% of them. Whereas thyroid autoantibodies can come positive in both, in Graves, which is hyperthyroidism, and in Hashimoto's thyroiditis, but more so in Hashimoto's thyroiditis. So how to say the difference? Using the TSH and the free T4. The free T4 is low, the TSH is high, thyroid autoantibodies are positive, diagnosis equals to Hashimoto's thyroiditis, the autoimmune variant. And how to start thyroxine in hypothyroid patients? Thyroxine has a half-life of 7 to 10 days, but a much longer biological effect. Therefore, once daily dosing is appropriate. And as in everything in medicine, all our doses, all our medicines, even insulin, we did it on kg body weight. And even this is no exception. We use 1.6 to 2 micrograms per kg body weight per day. to dose thyroxine in non-pregnant subjects. And in pregnancy, I dose it at 2 to 2.3 micrograms per kg body weight per day. Most adults, to get euthyroidism with proper Hashimoto's, will usually need about 100 to 200 micrograms per day. Now you may ask me, I have started thyroxine today, when should I next measure the thyroid function tests? Now, with all things in the body, it takes about 6 half-lives. If I give you any drug, it takes about 6 half-lives for you to excrete 97% of it. And because the half-life of thyroxine is such that it takes about 6 weeks to excrete all your thyroxine. So, if I give someone thyroxine today, say I started someone with 50 micrograms on the ward, there is no point doing the thyroxine tomorrow and no point doing next week. It's best done 6 weeks later to get a really good meaningful picture of your thyroxine dosage or duration. And my pregnant women patients, I do the same thing. Actually, I do it every 4 weeks. I cheat a bit. I call them once a month. I see them first week of May, and I've seen them hypothyroid. I start them on a thyroxine dose and increase the old dose. Then I give them a slip and say come back in 4 weeks, and 4 to 5 weeks the next appointment happens. They come back to me, and I look at the dose and I say, oh, your values are very good. You're well controlled. You're doing very well. Now, elderly patients with known heart disease should start with a daily dose of thyroxine of only 25 micrograms for 3 to 4 weeks, and reassessment of their condition before further increments of 25 micrograms every 3 to 4 weeks until the predicted dose is reached. And even in healthy young subjects, I usually like to start at 25 micrograms. I usually don't like to start at 50, I don't like to start at 100. I usually like to start with everyone, because I'm a little bit extra careful perhaps, but I like to start at 25 micrograms as the starting dose, and then I build it upwards. Now, how long does it take for TSH to normalize? Now, patients should feel some improvement within 2 weeks of starting thyroxine. And it may take 3 to 4 months for full benefit of the drug to become apparent and the TSH to normalize. So it does take that long. And monitoring for dose adjustments. So in primary hypothyroidism, the TSH alone can be used to monitor therapy. And the aim should be to maintain the TSH at the lower end of normal range, 0.4 to 5. Because remember, in hypothyroidism, your TSH goes high, above the upper limit of normal. So we like to maintain it not at the lower end of normal, that is not at 4, not at 4 and not at 3.9. Try to measure it at maybe 1.2, 1.5, which is more closer to the lower end of normal. That will be a very good result if you can do that. And symptoms are best relieved when the TSH is also at the lower end of this normal range. And it takes about 4 weeks for TSH to stabilize. I've just spoken about this. It's to do with the half-life. So 6 weeks is usually the ballpark figure for doing the TFTs. Now what happens if you have persistently elevated TSH? The commonest reason for TSH not improving in hypothyroidism is non-compliance. There is a rare cause, perhaps celiac disease could be causing malabsorption of the thyroxine tablets. But usually it's non-compliance. 99% of the time it's non-compliance. And now I'll give you another example. I had a pregnant lady. She was taking her pregnancy multivitamins. She was also hypothyroid. She was also taking thyroxine. And her thyroxine TFTs were still at normal. She was still hypothyroid. Can anyone think of what went wrong? Very good, excellent. She was also an iron. And iron causes malabsorption of thyroxine. And because she was taking both the multivitamin to contain the iron in the morning and the thyroxine in the morning, the iron in the morning was causing malabsorption of the thyroxine. So the simple answer is take your iron tablet at night and take the thyroxine in the morning. And I've covered about pregnancy. If thyroxine requirements go up by 20 to 25%, i.e. 2 to 2.3 micrograms per kg body weight per day is the dose needed for pregnancy. And I like to see all the pregnant women. I usually see them on Tuesday mornings at my high-risk pregnancy clinic, and I really enjoy looking after them. And many of them come with thyroid diseases. Because the whole thing about pregnancy, is that children who are born with hypothyroidism, inability to live in pregnancy, are an increased risk of neuropsychological impairment. Now, what if someone wants to plan pregnancy, a woman wants to plan to conceive, and she is taking thyroxine? And they can be advised to increase their dose of thyroxine by 30% at the first time they get the confirmation of the pregnancy test. And this is something, if you are not happy to start in the community, you can more than happy give me a phone call and I'll tell you how to do it, and suggest you how to diagnose the thyroxine for the patients. And TSH should be monitored every 8 to 10 weeks during pregnancy until further dose adjustments are necessary, and angiotensin every month. After breastfeeding, the thyroxine dose returns to its pre-pregnancy dose after delivery when the mother is breastfeeding or not. Soon after delivery, you can put them back on the normal thyroxine dose. And many of my patients in the antenatal wards, after they gave birth, I put them on the original dose and sent them back. Now there's one entity called subclinical hypothyroidism. So what does that mean? Yes, you have raised TSH, hypothyroidism, yes, but normal T4. Now that shouldn't happen. Normally you should have a low T4, but these people have a normal T4. That's usually subclinical hypothyroidism. Very briefly I'll touch on this. The need for treatment in this instance is debatable, and you can send them to our clinics, and what we do is we usually look at the patient as a whole, and if they have strongly positive autoantibodies, which looks like Hashimoto's disease in evolution, that means you got the patient early, you must have got them before the autoantibodies caused full destruction of the thyroid, so you got them early and done a good job, send them to our clinics, and then we'll monitor the thyroid function tests every 3 to 4 months. We'll call it to our clinics, and every 6 weeks we do TFTs. And if we see the TFT is worsening, then we will start thyroxine in this patient. And especially if they have cardiac risk factors, we will start thyroxine in these patients. Now we'll move on to vitamin D deficiency. Last section of my talk is about vitamin D. Now this has got very good press. Now it's recognized not only important for the bone, it's also important for neurology, for good brain function. It's claimed to prevent or delay dementia. It's claimed to be very good for your immune system. So it's got a very good name. And there's so many articles which came out of this recently, review articles in journals praising vitamin D. So vitamin D deficiency, unfortunately, is quite common and affects a significant number of our population. And it's important for the maintenance of your bone health, because if you are deficient in it, it leads to osteomalacia and potentially fractures. And vitamin D can be easily assessed by just measuring the 25-hydroxy vitamin D assay, a very simple test. I'll come later to future slides as to why am I referring to 25-hydroxy vitamin D. I'll come to later slides about that. And replacement vitamin D can be tailored for each patient. It depends on the severity of the deficiency. And toxicity is unlikely if vitamin D is administered because it has a very wide safety window. And the adequacy of replacement should be monitored, and in cases of persistently low concentrations, malabsorption condition should be excluded, just as in thyroxine. Now, what are the consequences of vitamin D deficiency? Now, this country is well known for abundant sunshine, so we really shouldn't get vitamin D deficiency. And I'll come to another slide which shows how many minutes of exposure we should be recommending to our patients in Townsville to not get vitamin D deficiency. But coming back to this, it is very surprising that we still have vitamin D deficiency in our population with very good sunshine levels. We don't even have a cover of ozone in this overlay of this part of the world, and we still have vitamin D deficiency. And it contributes to osteoporosis, it contributes to falls independent of osteoporosis in the elderly patients through unknown mechanisms. And vitamin D deficiency has also other benefits and linked to other diseases such as cardiovascular disease, cancer risk, mortality, and multiple sclerosis, even epilepsy. So there are two main forms of vitamin D, which is cholecalciferol and ergocalciferol. I'll go straight to the diagram. So a vast majority of the vitamin D in our body is actually got from our skin. The major source is our skin. The minor source is our diet. The diet, very few foods can give you vitamin D, predominantly fish and dairy products. So what happens in the skin? You have cholesterol being measured in the skin. You have those two compounds, ergocalciferol and cholecalciferol. They get hit by UV vitamin D rays, and then they undergo changes, and they form the 25. They form the inactive form of vitamin D, which is the 25-hydroxy vitamin D3. And then the 25 vitamin D3 goes to the kidneys and gets 125-hydroxy vitamin D3 and 125-hydroxy vitamin D2. And these activated forms of vitamin D have main functions, enhancing the absorption of calcium and phosphate from your small intestine, inhibiting your PTH, and mineralizing your bone cortex. And that's why in renal failure patients, you have a lot of end-stage kidney failure patients in the community. in them the kidney is not doing its job. It's unable to cause the conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. And because it's not doing its job, they have vitamin D deficiency in that instance. And that's why there is less of vitamin D. So it does not inhibit the PTH, and so the PTH overworks. And the calcium goes low in renal failure, and then they get tertiary hypoparathyroidism, and all hell breaks loose. And that's why we have, I'll come to later slides, the treatment specifically for renal failure. We give the 125 form itself, just for them. So coming back to this, the main source of vitamin D is from your exposure of your skin to the sunlight. And it is said that we need about 7 to 9 minutes of sunshine exposure in summer months in Townsville, outside the hours of 10 a.m. to 2 p.m. and about 9 to 13 minutes of sunlight exposure every day, outside the hours of 10 a.m. to 2 p.m. in winter months in Townsville, to get our adequate dose of vitamin D by sunlight alone. And it differs from city to city. So dietary source is only a minor source. And if you bank upon dietary source alone, you are unlikely to get all your vitamin D requirements. Which is why some of our foods are supplemented with vitamin D, like our milk. And there are controversies with sun exposure. You can't tell everyone to go and expose them to the sun. Some of them will be renal failure patients and anti-rejection drugs. You send them to the sun, they'll get skin cancers. Some of them may get old tiny little basal cell carcinomas which go to the sun and they get activated and they get larger basal cell carcinomas. So we have to be a little bit careful. So guidelines on sun exposure must be tempered because of the high prevalence of skin cancers in this part of the world. So there's been much controversy. Dermatologists have always argued about guidelines, and that's why we don't have any guidelines as to how much we should expose ourselves to the sun. Go straight to the graph. So here it is. This came out in Australian prescriber about 2 years ago, and this is how much adequate exposure to get our vitamin D in our skin from sunlight exposure in Townsville. It's very different to other cities, as you can see. Very interesting to see Melbourne in the winters, almost 52 minutes in the winters per day you spend to get your vitamin D. So diagnosing vitamin D deficiency, again, the patient is asymptomatic. Very, very few symptoms. You can't even make out a patient with vitamin D deficiency. Many of our house officers in the hospital, junior doctors, they have their vitamin D measured and they're all 15, 20, very, very low, spending too much time in hospital. So it's very asymptomatic. And the signs and symptoms include muscle aches and vague muscle aches, vague muscle weakness, vague pectoral internal problems. That's all we ever get. It's often seen in older persons with osteoporosis. And there's debate about the benefit of vitamin D supplementation to prevent osteoporotic fractures. But what I can definitely say is, if you have someone with osteoporosis, giving them vitamin D alone is not going to strengthen their bones. They need to have the bisphosphonates in addition to that, or other bone strengthening agents like raloxifene and strontium to strengthen the bones. But vitamin D is important. You cannot start someone with osteoporosis on bisphosphonates alone in the absence of vitamin D. They should be given vitamin D, they should have the levels measured, they should be replenished, and then we start with bisphosphonates. So what are the values? No need to worry about this. The lab will give it to you in brackets below the level, and the lab will tell you what's normal, what's abnormal. And I like the way they use the words deficiency as opposed to insufficiency. So someone with 50 to 25 has deficiency, 25 to 50 is insufficiency, 50 is the cutoff limit for lower limit of normal, above 50 are normal. But still then, some clinicians like to say even they're not satisfied even with 55. Yes, it may be in the normal limits, but they try their best to put it close to 9500, especially in elderly subjects. And it's a very common phone call. I got this phone call from one of the GPs in my last hospital. Very good phone call. You may ask me, you have done the calcium levels on your patient, and now your vitamin D level is low, but your PTH level is high. So you may be wondering, does your patient have hyperparathyroidism? It's a very good question to ask. The answer to that is no. The patient has secondary hyperparathyroidism, and you get the high PTH levels when you're vitamin D deficient. So that's a normal response. When you are vitamin D deficient, your PTH levels go mildly elevated. It's a normal response. Secondary hyperparathyroidism. And all you got to do is correct the vitamin D deficiency, and your PTH will come back to normal. But if your PTH level is high, the calcium level is high, the phosphate level is low, that's proper primary hypoparathyroidism. That means one of the 4 parathyroids is overworking, and someone like this should be sent quite early to my clinic, and I'll be doing systemic scans and ultrasound scans of the neck. I'll pick the tumor and I'll send it to surgeon, remove the tumor and take it off. Now, vitamin D supplementation. The lower the vitamin D serum concentration, the more aggressive the replacement therapy is required to achieve the acceptable concentrations rapidly. And the greatest benefits are seen in high-risk individuals. So, how do I like to replace it? If I see someone with deficiency, insufficiency, whatever, anything less than 50, what I like to do is, you know that each tablet 1000 milliunits is equal to 25 micrograms. So I like to give about 2 tablets of those per day for 1 week, and then I give 1 tablet of that for the once a day, and also like to do calcium as well, 600 milligrams on the first day, and I monitor the patient after about 6 weeks to see if the vitamin D deficiency has been cured. Daily requirements of vitamin D, around how much are the RDA specifying for all of us, required daily allowances, 800 to 1000 international units, but larger doses are needed for those who are already deficient. So for moderate deficiency, you can give 15 to 25 nanomoles, which is about 300 to 5000 international units. And for severe deficiency, very, very severe deficiency, there's an intramuscular form. And if that's too difficult to give, I'll be more than happy to give it in the clinics once I get the referral. And this is especially pertinent for patients with malabsorption, acute medical illnesses, or poor dietary compliance. That's for whom we give the intramuscular, but it's very, very rare. I've never seen a single patient given that. In any case, in this part of the world, we need to get it all done by special access scheme and have to do a lot of paperwork before we get the intramuscular form. So we usually don't bother and just give them the oral form. So assume I have a very severely deficient patient. Assume it's one of my house officers. The level's only 10. She's spending too much time in hospital. So very, very severe. I usually don't bother much about the intramuscular forms. I usually rely more on tablets and compliance with the patient. So cholecalciferol, the 1000 units is 25 micrograms. The multivitamin form, you may ask me, why can't I just give the multivitamin forms? The multivitamin form only contains up to 200 international units per tablet. So it's not adequate to replace someone who has vitamin D deficiency. So you need to give them the proper vitamin D. The calcitriol, remember I mentioned something about renal failure people? The renal failure because the kidney is not working. That conversion of 25 vitamin D to 125 vitamin D does not take place. So for that, that's why the renal physicians use calcitriol, which is the 125 form of vitamin D. And we should be only using renal failure patients, and renal physicians will use it, but they should not be used. This form should not be used on your non-renal failure patients, which is your general population. For general population, we just use the ordinary vitamin D. And calcium, I usually give about 600 milligrams of calcium per day. Now this was another point I was asked to address today about nursing home residents with very severe vitamin D deficiency. Should we bother replacing it? And the answer to that is yes, because it has other benefits as well. It has cardiovascular benefits nowadays, it has immune system benefits. It's even deficiencies even been linked to risk with falls. So if you can prevent falls by giving a tablet, in theory it's going to be very good for your elderly patient. You can prevent fractures. So yes, if there's a very severely deficient vitamin D deficient patient in a nursing home, I would give the tablets. I wouldn't hesitate. My thinking may be different from others, but I strongly believe they should be treated because of other benefits, not just importance. And that's actually the last slide of my talk. Just a conclusion that vitamin D deficiency is quite common in this country, and it can be easily measured by using the 25 hydroxyvitamin D concentration, and replacement is to be tailored depending on the degree of insufficiency. But I like to use 1000 international units about twice a day for 1 week, and then I give 1 tablet once a day, and after 6 weeks I check the level. And if vitamin D is still low or proving difficult to replenish, ensure that compliance is there, and ensure that your subject does not have celiac disease or malabsorption. And now I was also asked whom to refer to clinics. Feel free to refer all the patients. You can start them on Romex 30 for insulin, type 2 patients. It's safe to start a small dose of 8 to 10 units. It's not going to be dangerous. And you can send them to our clinic. By the time I get to see them, I'll do HbA1cs. Thyroxine Thyroxine, you can start a smaller dose like 25 micrograms. If the referral takes too long, you have the benefit of knowledge. Every 6 weeks is how long it takes to check your levels. So every 6 weeks you can change it, you can check it. And if it's still hypothyroid, you can increase the dose by another 25 micrograms until you get fall in TSH. And TSH is more sensitive than T4. And for vitamin D, home to center clinics, that's a very easy thing to replace. You can easily replace it in the community. And doses are difficult for you to follow. MIMS often gives the correct way and the appropriate way for each different formulation, because there are millions of drug companies selling vitamin D. So MIMS will tell you exactly which company, how to do vitamin D, how to maintain the slightly lower deficiency levels, how to get them back to normal levels. So yeah, that's the last slide, and I'm very thankful to all of you for calling me to this talk. Sadly, the powers above, the consultants who interview candidates, sadly have sent me to the Gold Coast Hospital. So I'm going to miss all of you, and I really enjoyed looking after your patients. Some of you must have read my letters, and very, very sad to leave all of you. But I've kept good relationships with all the Townsville Hospital staff, and hopefully they'll take me back here in 2014 when I come back as a consultant. And I know that it's difficult getting private practitioners here, but I'm more than happy to come back here by 2014, and I'll be standing here again and giving talks no doubt. So thank you very much.
Something about low vitamin D levels in pregnant women.
Yes.
Do you?
It's a very, very good question. Excellent. Yes, it should be replaced in pregnant women as well.
In the same manner, or are you a bit more aggressive?
Excellent question. Thyroxine is a little bit different, a little bigger dose than normal. It will be exactly the same dose, exactly as a non-pregnant subject. And then you may also ask me, insulin dose in pregnancy. You want to know what insulin dose in pregnancy? Yes, insulin doses also go up with pregnancy. But the good thing is our clinic is very robust over here, and we see lots of pregnant women on Tuesday mornings. We get about 20 to 24 every Tuesday morning to see between Dr. Tan, myself, and the other registrar. So we'll deal with the insulin with the GVMs and platforms.
Just a question about, that was the right question about the nursing home patients. So if we do a vitamin D level and it's low, should I then follow that up with a calcium and a parathyroid hormone, or can I just treat their deficiency and see what their result is after?
Beautiful question, lovely question. That's exactly what to do. It's very difficult for the nursing home subjects. Many of them have dementia, many of them can't talk, many of them are not eating well. They get fed 2 to 3 times a day. So doing calcium pediatrics, I would just have a small dose. No, I probably wouldn't even do the way I did it for a deficient individual. Deficient individual, you have to build it up for 1 week, and then you have to give once a daily dose. In these people, I'd probably get away with it and just give at least 1,000 units once a day. At least they're getting something. And a calcium tablet, calculate once a day. And that will be enough for someone who is dementia and nursing home can't eat. That will be enough. So the answer is, you don't have to be very aggressive with these nursing home patients. Yes.
How often do you check the TSH once they've got on the senior state?
And for that, again, it's 6 weeks.
How long once it's stable?
Once the thyroxine is stable, very good question, 3 months. And if it's even more stable, 6 months, and some of them even 1 year. And the Australian prescriber says, you even check it 1 year. If your patients are very stable and doing very well for the last 2 to 3 years, then you can check it once a year.
Is that no more questions? Thank you. Well, thank you very much, Dr. Aranha. That was very practical. The talk is already on the website, so if you want to get more information as you need to in your practice, then just go onto the TM website. But yeah, that was great. That was very practical.
My pleasure, Dr. Hella. And yes, and if you want to get my talk, you can email it to me, and I'll email all the slides to you anytime you like.
Yes. So just a bit more housekeeping. Just some advertising of what events are forthcoming. We've got a takeaway mental health skills training on the 29th of October. There's a Women's Health Beat the Bladder Blues held at Townsville Family Medical Practice on the 1st of November at 6 p.m. We have our next MARTA meeting, not at the MARTA, but at the Picnic Bay Surf Life Saving Club, and the plan is to have it on hypertension with a panel. So I'm arranging the panel at the moment. We're going to have 2 physicians, probably a cardiologist, a general physician and a dietitian, and I'll encourage people to either email me cases and then get empowered to address those questions. So a bit more interactive than our normal presentations. And so this conference, so that's on the 16th of November, and this conference room is closed from the 15th of October till the end of the year. That's all I can say. Thank you again to Pfizer for sponsorship.
I can't get on the side.
Thank you. I didn't even notice it in the parking lot. Oh, fantastic.
So that's thank you. I want to see how the that's what I want.
There we go.
Can I ask one quick
Go for it, my dear.